This is Jerry Hesch at Hesch Institute in Aurora, Colorado, and I treat joints throughout the whole body, and have developed an approach to treating these joints. I have published a book and 3 book chapters and a couple of articles, and taught, many workshops, more than 100. And my client Alan comes from California. He's in the military, and he's a data analyst. Not good if you have back pain, because that means you have to sit 8 hours a day. So he's been fairly disabled since what month? April?
August.
August. Can you tell us what happened in August?
Sure. So in August, after walking with my family for an entire day, right before I went to sleep, what I felt, my lower back and my lower portion of my body started to give out. I literally fell on the floor, and I haven't been the same ever since.
Okay. Now, do you want me to keep your face out of the video?
Please.
Okay, we'll do that. So, you also were getting spinal adjustments at that time?
Correct. Before I went down, as I said, I was being treated by a specific chiropractor. He had a different methodology than I previously understood what a chiropractor was. And
can you elaborate?
Sure. So one of the techniques that he would do once a week was hit me with the palm of his hands, particularly around my SI joint area, and I believe to this day that was one of the causes of my this current episode that I'm going through.
So that's certainly an interesting technique you're describing.
Yes.
Can you demonstrate it on this model?
Sure.
Hang on 1 second so I don't get your face. All right, carry on.
Okay, so the chiropractor would literally hit me around this area.
How hard?
Pretty hard.
Show me. Oh my gosh.
Yeah.
Okay, all right. Okay, all right. That's a weird technique. I'm not a chiropractor. I can't really comment on that other than to say that strikes me as... My work is very gentle, so I have a very different philosophy than that practitioner. Okay?
Yeah.
Now let's have you lie on your back, please. So your straight leg raising was full. Your hip motion is full in all directions. It's interesting when you sit or stand, you have considerable muscle guarding, muscle spasm along the entire right lumbar paraspinals. Okay? A little bit of the thoracic gets included in that. When you lay on your stomach, they relax. I can actually indent that muscle. But why don't you go ahead and sit up and face the bookshelf? So let me pull your shirt up if you don't mind. Okay. And so I'm on both sides of your spine, of course. And I'm in the mid to lower thoracic. And your muscle tone is pretty symmetrical, pretty, normal. And then when we come down about here, okay, this thumb, I think the camera can capture that. Right here we're pretty symmetrical, and then right here this really sticks out. And I can indent the muscle on your left side. When I try and spring through that muscle, I get a little bit of yield, a little bit of giving, but not much. And same thing here, that's just really pronounced. And same thing here. And then now we're on the bony pelvis, and that feels symmetrical. Muscle tone overlying the sacrum feels pretty normal. Again, increased tone on the right paraspinals moving in. Again, increased tone on that right side, still there. And then over here it neutralizes, okay? And then if we come out lateral, okay, so I'm no longer, I don't think I'm on the quadratus anymore, okay? I think I'm more on the lats and the little bit of the lateral part of the lats and the external obliques and such, and those feel okay, and I walk around into the anterior abdominal, anterolateral abdominal wall, and those feel okay. Okay, so I think we have some pretty significant erector spinatal tymphi and quadratus muscle guarding or spasm. Okay, the pelvic landmarks the right PSIS, I wiggle around on that little peak of a mountain, little peak, and I stop at the very top of it, and it's not subtle, okay? It is distinctly lower on that right side, okay? Sometimes it's really subtle, you know, to see a difference. This is not subtle. It's posterior, okay? It's prominent, and it is inferior. And then if I come on what I call the posterior iliac shelf, distinctly lower, not subtle, okay? And I'm going to walk around and look at the front of your pelvis. So what I do is I find the ASIS, this bump on the front of the ilium, and then I lay my extended hands on the front of the pelvis, which I call the anterior iliac shelf. Sorry about that. Little tender there, sorry. And I perceive it as being lower on the right. That's not subtle. So I trust what I see. If it's subtle, I really question it. But sometimes it's very, very obvious. And that's the case with you.
Okay.
Can I have you lie on your back? So your leg lengths are equal. All of your hip motion is good. Okay, all of the hip provocation tests were normal. I'm going to test side glide of your pelvis. So I'm shifting it over to the left and I can spring it. And then I'm doing the same test, gliding it over to the right, springing it, and that moves well. With you on your back, the right ASIS is actually deeper. It's more posterior. And if I come underneath it, it's too subtle. If I put my extended fingers on the shelf, it's really subtle. So I cannot say. It's more obvious when you sit. On the left ilium, I'm rotating it posterior, so I push to a stop point and then I spring it, and it does spring and recoil just like a shock absorber. And the SI joint is, among other things, a shock absorber. On the right side, I cannot take up the slack. I'm putting a lot of force there, much more than on the left, and there's no movement at all. Okay? I'm going to do an inferior spring. There's no give there at all. Feels like a brick wall. Lie on your stomach. So when you lie on your stomach, again, that the muscle tone relaxes on the right. Okay? The posterior iliac shelf is lower on the right. That's not subtle. If I come underneath the sit bone, it's too subtle for me to tell. Okay? I'm going to do a superior spring. We did spring tests on your sacrum. Your sacrum moves beautifully. The force translates through the SI. Now, I cannot take up the slack going superiorly. Okay? Now I'm going to go inferiorly. And we have good spring mobility on the right. Oh, sorry, the left. Hello. And on the right side, I cannot get any movement. Okay? Your right SI joint is stuck. Why is it stuck? Is it stuck on the inside of the joint or from the outside? Nobody knows. Nobody knows. So I'm checking the sacrotuberous ligament. I checked your long dorsal SI ligament and it had normal tone. And then I'm on your left sacrotuberous. I can indent it slightly. It's supposed to indent a little bit. And then I'm looking for this one, and this one's more subtle. Okay, there it is right there. Okay, and I can indent that one, and that's softer. Okay, I think the camera view shows that that's, you know, that I can spring that a lot deeper than I can spring this one. Okay, so when we have blocked motion up or down, especially up, and the sacrotuberous ligament is softer, that occurs more often with an upslit, but it's confusing. That's a confusing piece of your presentation, is the ligament being softer. Okay? Because otherwise, you also do not have forward rotation. Okay? So we could call this a posterior ilium, extremely rare on the right side, although I know that another SI expert in Georgia named Vicky Sims believes that right posterior ilium with an upslip is very common. With my spring test, I just don't find that. I just don't. But you could be a posterior ilium. Okay, that's a possibility. So that's the first thing that I'll treat you for. I would give consideration to the possibility that it could be coupled with a downslip as well. Little bit mystified by the softness of that ligament, but if it is in fact a posterior ilium, we would expect it to be tighter. So it's throwing me off. You know, but your anatomy could be different than the average person's anatomy. And research has shown, really good anatomical research has shown that individuals can have a different SI joint shape from one side to the other. Okay? So for right now, I'm going to put it in abeyance, the fact that this sacrotuberous ligament is softer. Okay? All I know is that motion through that ilium that goes through the SI is blocked in terms of upward movement, downward movement, anterior rotation, posterior rotation. Okay? So it's a really confusing presentation for me. And the only thing I can do is start somewhere. Do something. Challenge the joint and see how it responds. So if someone has a posterior ilium, we don't know if that really happens inside the SI joint or not, because research, good scientific research has shown us there's very little true motion inside that joint, even with injuries. Okay? It only moves less than 2 degrees of rotation and 2 millimeters of glide in any direction. Okay? And even less than that. So a lot of this stuff, when people have an uneven pelvis, even with blocked passive mobility, it can be the entire pelvis twisting about an offset axis. And that motion can be happening pelvis related to the lumbar spine and in the hip joints. Okay? So could this be inside the SI? Maybe, but we have no way of validating that. Looking at pelvic alignment really does not inform us about what's happening inside the SI joint. But I do know that motion is blocked going through that joint. Okay? So I'm going to treat it initially for a right posterior ilium, and we'll see where that takes us. It could be that there's a few different mechanical things going on. So let's proceed and do treatment, okay? So lie on your left side. So what I'm going to do is bend this hip up. And you have good hip mobility, so I can bring it up to 90 and it does not rotate the pelvis back. Okay? So I'm going to support it. I want you to relax. And then I find the top of that ilium, the shelf, and I pull it forward. Okay? So my elbow is extending and I'm pulling the ilium forward at the top of it. Okay? Then I'm pushing through your thigh posteriorly. And now everything is locked up. Okay, it's called a force couple. And now I do little oscillations. I'm just pushing into your thigh with my belly. And oftentimes with the male, we have to do this at 60 degrees. You know, just because their hips are really tight. If it was me, you'd probably do it at 60 degrees. But most females, we can do it 90, and you have enough hip mobility that we did that in 90. Okay? So let me have you lie on your back, please. just because we have limited research on the SI joint, just because we don't know if we can evaluate objectively the amount of movement in that joint in the clinic, it's not an excuse not to treat the pelvis and the hip and the lumbar spine. Okay, so I'm going to see if I can take it the slack, and the answer is yes, I can take it the slack in posterior rotation, and I can spring it. Okay, it goes into a little more movement and it recoils. So let's have you lie on your stomach. I can take it the slack now and I can spring it out. So I'm on top of the bony pelvis on the posterior iliac shelf. I can take up the slack now. And I spring it and I see the force, I see your heel move up and down. So the force is translating through your SI, into your hip, into your knee, into your ankle, into your subtalar joint. Okay? The next movement I want to test is forward rotation. The alignment is much better. Okay? This right side is no longer lower. PSIS on the right is no longer lower. It's no longer posterior. And so now I can take up the slack in forward rotation. I can spring it. It springs and it recoils. And so I'm going to come back and evaluate that ligament again. Okay. And that feels tighter. Can you tell? Mm-hmm. Okay, that ligament is tighter now. And I don't know why. I don't have a good biomechanical explanation for that. I'll think about it and, I'll discuss it with you tomorrow. But off the top, it's a mystery. Okay. Sit up and face towards the bookshelf, please. So earlier, you had greater muscle tone in the right lumbar spine and a little bit in the lower thoracic. No longer. That muscle is very soft. Can you walk down the hall and then come back and tell me how you feel?
Sure.
I'll comment and say that I like that technique for treating a so-called posterior ilium, whatever that is, much more than the muscle energy technique. I don't find the muscle energy technique effective in restoring that passive mobility. So you have an interesting look on your face.
Yeah, I feel more aligned.
Okay.
Especially on the hip area.
Okay. Alrighty, so say that again.
I feel more aligned, especially around the hip area.
Okay. I wish I could film your face because you have an interesting look on your face.
Man, that's great. Feel great.
Go one more time. Walk down the hall one more time and then come sit in this chair.
Feel great.
Wonderful.
Yeah.
What's great? What does that mean?
For one, I don't feel
Come and sit in the chair.
Sure. I don't feel the tightness around my hip area that I was feeling before. And it's just a different feeling, especially on the right side. I feel it's more loose than I came in with this morning.
Okay. And your pain rating's been pretty high, like the low number is a 4. Correct. But if you go to the grocery store and then come back home, you have to go lay down.
That is correct. I haven't been able to do much, again, ever since last August. I have to take my pain medication just to go get groceries and come back home and lay down and continue on.
And your pain gets up to about an 8 or a 9 if you do
correct.
that?
It is correct.
Okay. Well, tell me how you feel in sitting now.
I feel great. I don't feel the pain that I felt before on my sacrum. Constantly as I have to work 8 hours a day. I would have to work through the pain. As I sit here, I no longer have to kind of feel around to see if there's some pain around, I can just freely sit down and I don't feel the pain I came in with.
Wonderful, wonderful. So I want to up your endorphins so you'll have less pain.
Okay.
Okay? I'm from Santa Fe.
Okay.
Lived in Albuquerque forever. Karen's from Albuquerque. My boys live in Albuquerque. So I want you to go, like you said you wanted to go tour downtown Denver.
Correct.
Okay. Go hungry and go to Little Anita's.
Okay.
They're from Albuquerque.
All right.
And go order a blue corn, red chili, chicken enchilada.
Okay. Looking forward to that. Yeah.
All right? And then report your findings.
Okay. All right. We'll do.
That'll give you a big blast of endorphins, I promise you.
Okay.
I would join you, but I have so much work to do.
Got it.
All right. Listen, this is a very interesting presentation, and there was a mystery. You know, I really didn't know if that was what they call a posterior ilium. I think I made it clear I'm just not interested in the debate on the SI joint or is it the pelvis, you know. I'm interested in helping people. I'm interested in restoring normal functional movement to reduce nociception, to reduce pain, and to improve function. That's where my heart is.
Okay.
You know, we can debate all night long on the internet. You're wrong, it's this, it's that, you know, and it's like, you know, I think the proof is in the pudding, and I think we just had a nice bowl of pudding right there.
All right, thank you, appreciate it.
And yeah, thank you. So what we do is we don't teach you how to self-treat this today.
Okay.
I want to see what happens with you just, you know, going about your normal day, coming back 24 hours. You've had lots of forces going through that pelvis. Standing, walking, sitting, turning in bed, you know, all that. And so tomorrow we'll reevaluate it, and it could present with a little bit of a different pattern. That's called a permutation. Sometimes that happens. But I will definitely tomorrow teach you how to keep this movement.
Okay.
Okay?
All right.
So I'm only going to see you 3 times. I'll teach you a good home exercise program. Okay. I'll teach you good body mechanics, a little bit of ergonomics. And I'm really encouraged, and I think you are as well.
Yeah, definitely.
Good. Well, thanks again.
All right, thank you.